Want to thank everyone for joining us here today for our webinar on bone health in thalassemia. I'll start out by saying that this program is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $75,000 with 0% financed with non-governmental sources. The contents are those of the author and do not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. And for more information, we please ask you to visit hrsa.gov. And now I'd like to turn things over to our speaker today on bone health in thalassemia. That is Ellen Fung. Dr. Fung is the director of the Bone Density Clinic at UCF Benioff Children's Hospital, Oakland, and enjoys educating clinicians on the importance of achieving optimal bone health in childhood and adolescence. She has a passion for hemoglobin disorders, including thalassemia and sickle cell disease, and has been conducting much of her research within these populations for the last 2 decades, for which I have to say we at the Cooley's Anemia Foundation are enormously grateful. So Ellen, I'll turn things over to you.
Thank you, Craig. And I'm enormously grateful to Cooley's for all of the support over the years for the work that we do here and in our population. So it is a delight to be here and to speak about bone in thalassemia. I have designed this lecture, as I mentioned just a minute ago, to be really an overview, kind of a summary of where we are in thalassemia and bone health, and then to provide, I think, some recommendations at the end about where we could go forward in the field in bone health. So the agenda for today is really to review a few of the uncommon problems that aren't really seen very frequently in our clinics now, but focus more on osteoporosis. But occasionally we might run into some of these things related to chelator toxicity. So I did want to bring them up because there's been some case reports. Then I'm going to be focusing on why we should care about osteoporosis in the population, risk factors, what bone compartments are most affected in our population, our screening guidelines, preventative measures going forward, and then a little bit on the current therapies and what we know about therapeutic opportunities in bone health and thalassemia. So as I'm sure you're quite familiar with, bone marrow hyperplasia is one of the primary morbidities in thalassemia, which leads to bone expansion, especially in the face and the skull due to overproduction of red cells in an attempt to compensate for the severe anemia that's experienced. So here's an image of an adolescent boy with E-beta thal who had not received transfusion therapy yet. So the typical phases that are observed in a transfusion-dependent patient or an intermedia who hasn't received enough transfusion. The extramedullary hematopoiesis is also when the bone marrow is unable to produce sufficient blood cells. The body compensates by stimulating other organs to produce the blood cells. And the image here on the top is a cross-section of a patient's abdomen where two masses are seen outside of the spine. And then the MRI image, the lateral MRI image on the lower region here is from a case report of a young male who had stopped transfusion and his hemoglobin dropped to about 5. And as a result, his body tried to make cells outside of the bone marrow, which led to the spinal cord compression and subsequent neurological problems. He was treated with hypertransfusion and his symptoms resolved. So in each of these illustrations, the bone changes occurred in patients that were receiving either inadequate transfusion or in patients prior to starting regular transfusion regimen or optimizing it. So that's not as commonly seen now. But chelator toxicity can be seen. So it can lead to changes in the bone. And in this image of the hand and wrist was a very high dose deferoxamine before the age of 3, which led to distal metaphyseal bone fraying, which is similar to actually what you see in vitamin D deficiency rickets. And then in the control panel here on the right are some lateral spine scans. Here on the left is a healthy 30-year-old male, lateral spine image by DEXA actually. And on the right is an adult male. This is also a DEXA image showing some vertebral shortening or platyspondyly. And these are where the height of the vertebrae are truncated because they didn't develop properly. We're not exactly sure why these bony changes occur, and some of the theories around this are that they're due to deferoxamine disrupting the endochondrial ossification, or because desferol impairs the proliferation of the osteoblasts, increasing urinary calcium excretion. It's also potentially could be due to zinc deficiency, but you don't usually see these kinds of bony changes in severe zinc deficiency. But this doesn't usually happen in most of our patients now because we're better able to know when to start chelation and not to do really high doses in young patients. So not frequently seen clinically. We've known that deferoprone is also related to arthropathy for quite a while now, and the recommendation is not to start deferoprone before the age of 5. But there have been a couple case reports, one in 2013 by Sharma, and the more recent one reported by Dawan in 2020, where some patients actually started deferoprone between 5 and 6 years of age at a fairly reasonable dose, so at 75 mg per kilogram. Yet they still had some slowing of ulnar growth and radial bowing because of the slowing of the ulnar growth. That's something to keep an eye on. It's kind of unusual, but has been observed. And then there was also one of the 40 cases that were reported was an 11-year-old transfusion-dependent female who started deferoprone at 5 years of age and also had ulnar shortening. So these are some things that have been seen fairly recently and something to keep an eye on. But by far the most common type of bone disease is osteoporosis, and what I'm most familiar with in treating in our bone density clinic here at UCSF. It's the what I'm going to be focused on the rest of the talk today. So up to 60% of adults with THAL in the United States have low bone mass. And the definitions that are used before the age of 50, if an individual has a significant fracture history, which means 2 long bone fractures before the age of 10 or 3 long bone fractures before the age of 18 would be considered osteoporotic, or if you had a vertebral fracture, or they're defined as low bone mass by a BMD Z-score less than or equal to -2. In our patients over the age of 50, we use the WHO criteria, which is an osteoporosis by a BMD T-score by DEXA of less than -2.5, and low bone mass, or an old term that used to be used, is osteopenia, which is a BMD T-score less than -1. So why is osteoporosis a problem? So anyone can, break a bone when you face a significant trauma like a car accident, but having osteoporosis makes you more likely to have a fragility fracture, and breaking a bone when you, say, trip off a sidewalk. So having many microfractures in your spine can lead to overall loss of height when you age and lead to kyphosis, which also can impact pulmonary function ultimately, as well as significant debilitating bone and back pain. And very severe osteoporosis can even affect the mandible and lead to tooth loss and then affect dietary intake. So it's not really a silent disease, even though that's often what's talked about in the literature, is that it progresses over time very gradually and so is considered silent, but can have pretty devastating effects. So you might say, why do you want to avoid fracture? What's the big deal? If you're going to break a bone, you eventually heal, right? But yeah, I mean, fractures actually are pretty painful. They are not without pain and also can lead to decreased mobility or a significant loss of function. And depending on the location of the fracture, it could lead to nerve damage or complications during the healing process, such as malunion, and leading to a limited range of motion going forward. And then, of course, every individual fracture increases the likelihood for future fracture. So it increases your overall morbidity going forward. So what about fracture in our patient population? You might think that maybe fracture is less common because our population of patients are less active, and so might be an overall less likelihood of fracture. But there is a bit of literature that we can look to with regard to fracture prevalence and fracture incidence in our cohort. So these images on the left here are from the TCRN study many years ago, where we looked at a cross-sectional cohort here in the United States and Canada. And what I think is most helpful from these images or these figures is to show that fracture increases with age, which is not surprising. You see that in general populations, but 60% of our transfusion-dependent patients on the very left side here had a likelihood of or prevalence of fracture. And it wasn't just related to our transfusion dependent, but also our transfusion intermedia or our THAL intermedia patients also had a really high likelihood of fracture. So it increases with age. It's not necessarily just in our transfusion dependent patients. It's also in our non-transfusion dependent patients. and that bone and joint pain is very common in our patients. On the figure on the right is a more recent paper that was looking just at the non-transfusion cohort and found that they had a 1.35 increased risk of fracture in comparison to healthy controls. So there definitely is an increased risk of fracture. And then recently, our group looked at a retrospective study of 126 cases of thalassemia in our cohort here on the West Coast, and found fragility fracture was presented at 21%. And this was in a relatively young cohort. Fragility fracture is defined as a spontaneous non-traumatic fracture or a fracture that occurs from a fall from a standing height. So it's an incredibly high rate of fragility fracture in a really young cohort of patients. So it's not just that patients are fracturing at a likely higher prevalence than healthy controls, it's where and how they're fracturing that's quite important. So vertebral fracture is often referred to as vertebral height abnormalities that you see on a lateral X-ray or a lateral DEXA. And these lateral images here are images from a DEXA machine. The one in green is a healthy 30-year-old male. The one in the red bars or the red boxes are patients with thalassemia, relatively young patients. And you can see both severe wedge-type fractures in this 31-year-old female patient and moderate crush-type fractures in a 22-year-old female and a mild wedge-type fractures in a 24-year-old, all transfusion-dependent patients. There are a number of investigators that have estimated the vertebral fracture occurs in anywhere between 9 and 16%. That was from the TCRN study, and then a more recent study found that 13% of transfusion-dependent adolescents actually have vertebral height abnormalities. Again, this is really quite incredibly high percentage of patients with vertebral abnormalities in such a young age of patients. So clearly getting at the morbidity of the bone issues here. But it's not just the morbidity of the structural changes, but it's also pain is quite common in our patients. And I think all of us know this and see this in our patients are seeing this clinically. The TCRN study reported that 50% of adults reported pain in the previous month, and pain is reported to be both acute and chronic, as well as localized or diffuse throughout the body. But there's a number of etiologies behind this pain. It could be the back pain could be related to a vertebral fracture, it's possible, or to marrow expansion, but it can also be related to extramedullary hematopoiesis, or there could be some degenerative spine changes or vertebral changes that are happening in our patients as they age. Iron overload can lead to arthropathy, as well as chelation and musculoskeletal pain can come just from chelation itself. Or avascular necrosis. It's more common in our sickle cell patients, but we do see it occasionally in our thal patients. So pain severity and the frequency of pain doesn't always correlate with hemoglobin concentration or low bone mass, but low bone mass is likely related in some shape or form in many of our patients. So transitioning back to our most common skeletal issue, or osteoporosis, what leads to it and why does it happen? At its core, it's an abnormal bone remodeling issue. You may remember that bone is a constantly turning over tissue. So it starts with a quiescent stage. It leads to an activation of the osteoclast, which leads to resorption at the bone lining there. The reversal of the process where the osteoblasts come in lead to formation and mineralization of the newly formed bone. So it's a cycle that's occurring on a regular basis. And for most individuals, that cycle is in balance. So in healthy adults that are at their peak bone mass and not losing bone, there's a balance between bone breakdown and bone formation. And in children, the bone formation is greater, but in our patients with thalassemia, there's much more bone breakdown than formation, which leads to an overall loss of bone. And this has been looked at in a variety of different publications over the years, where markers of bone turnover or bone resorption have been elevated in almost every study. So all of these different circulating markers of bone resorptive activity is elevated in many of our patients with thalassemia. And there's a reduced markers of bone formation, such as osteocalcin and PINP and IGF-1. All of these are known to be lower. The only one that has been shown to be less reflective is alkaline phosphatase, but it's also not always specific to bone because there's lots of different alkaline phosphatase. It could be more reflective of liver alk phos. So, but pretty consistently, we see an increase in resorptive activity and a decrease in bone formation. And so then this is reflected in what we see in the overall skeletal tissue in our patients. So we looked at this a few years ago in a cohort of our patients here at UCSF of young children with thalassemia, and we looked longitudinally. So all the patients had to at least had to have 2 DEXs over a period of 5 years, and actually over a period of 10 years. So there's 34 patients that were included in this cohort. And what you can see when it's plotted here, just with the APBMD Z-score plotted against age, is you can see that Z-score declines with age. So they're not accruing bone like they should. If Z-score remained consistent, then there would be accruing bone like you would expect. So they're not accruing bone, so they're losing bone mass over time. And then if we compare the results to a large healthy cohort, that was the bone mineral density cohort study that was published back in 2018. If we are able to calculate then from that reference data set what would be the expected velocity, we find that 60% of our youth have reduced bone velocity, meaning that they're not accruing bone, they're not gaining bone like they should. And ultimately, then that leads to a reduction in their genetic potential to reach peak bone mass. So they're not gaining bone as they should. So a reduced capacity for peak bone mass. So this brings us to kind of individuals and what their risk factors for osteoporosis are. And having a hyperactive bone marrow with inadequate transfusion is really at the top of the list as what is leading to, or what is leading to the etiology of osteoporosis. But also chelator toxicity, as I've mentioned, can lead to an increase loss of bone-forming nutrients like calcium and zinc, but too much transfusion without adequate chelation can lead to iron overload, and iron can be toxic to the bones. I'm going to get to that in a second, but it can also lead to hypogonadism and hyperparathyroidism and growth hormone deficiency and diabetes, and all of those endocrine dysfunctions can then lead to osteoporosis. And then we can't forget all of the lifestyle factors, so a reduction in physical activity. And we can't forget that smoking and extensive alcohol use can also have effects on bone. So these lifestyle factors must also be considered, not just the iron overload and the chelation and things. We can't forget that lifestyle factors can also have important impacts on bone in the population of thalassemia. So there's a balance between optimizing hemoglobin concentration and minimizing the effects of iron on the bone cells and how that directly impacts bone. So on the left side of the slide, this was sort of a nice summary that was presented in 2022 in Active Biomed and showed this relationship between anemia and iron overload. And so on the left side, where anemia can have a direct effects on bone resorptive and bone formation through marrow expansion, tissue hypoxia, hepcidin levels, and increasing erythropoietin can all increase bone resorptive activity. And though we don't really know what the cutoff is, there have been some studies in non-transfusion dependent patients that suggest that a hemoglobin less than 8 really is the cutoff to really affecting bone density. In the transfusion dependent patients, optimizing, transfusion with chelation is where we're focusing on our 10.5 range and so forth. So that's on the anemia side. Now on the iron overload side, we know that iron can also have direct effects on osteoblast bone forming cells. It can actually be toxic to osteoblasts as well as osteocytes, which are the key regulators of bone remodeling. And iron also increases bone resorption through intracellular oxidative stress to the osteoclast. And then this osteocyte apoptosis then can in turn increase expression of sclerostin and activation of rank L. And that can signal, thereby decreasing the bone formation and enhancing bone resorption. So iron toxicity can be toxic to the bones, and anemia can be toxic to the bones. So you really need to optimize hemoglobin and reduce anemia as much as possible without putting too much stress on the bone cells through iron toxicity. So then we wanted to look at just the characterization of what's happening in our thal patients and understanding which compartments of bone are most effective, because this helps us then to direct our therapies at the bone to be most important. So we've tried to understand this over the last number of years and looking about bone compartments and which are most effective. And these are some peripheral CT images or peripheral PQCT of the tibia, so a weight-bearing bone. And on the left is a 20-year-old female control. On the right is a 22-year-old female that was transfusion dependent. And what we found in this study was a cross-sectional study that there was reduced cortical density, there was reduced cortical thickness, so the cortical shell of the bone was thinner, and there was also reduced peripheral geometry. So the overall bone was smaller in size, which is often what you see in individuals that are not very active when they're young and forming bone. We did a similar study with a group in Germany and looked at HRPQCT, so high resolution PQCT imaging in eugonatal transfusion dependent, non-transfusion dependent patients, and hypogonadal transfusion dependent patients, and showed that there was overall decreased trabecular structure, fewer trabeculi, so the struts between trabeculars, and increasing trabecular spacing, or the spacing between the trabecular struts in hypogonadal patients. So showing the effect of hypogonadism on bone structure is really devastating. Thus, the reason for trying to replace the sex hormones as much as possible to improve bone health. More recently, there was a paper that was published by a group from India, which showed similar findings with reduced cortical thickness and reduced trabecular number, spacing, and density. What's fascinating about this group is that the transfusion dependent patients also were on folate and zinc, and those with really severe osteoporosis were put on zoledronic acid, but yet still had some of these findings. So it's really important then to try to prevent these things from happening rather than trying to fix them after they occur, because that's more difficult to do. So HRPQCT is wonderful. It's got these really cool, pretty images, these three-dimensional images, and we could see what's happening structurally with the bone, but not everybody has access to a HRPQCT. But we do have access to DEXA, and there's relatively new software called Trabecular Bone Score on DEXA that can lead to a better understanding of what's happening in the trabecular structure of the bone just by DEXA. So a number of years ago, MetaMaps created this software, which reanalyzes the two-dimensional images from DEXA and creates an algorithm that analyzes the spatial organization of the bone and comes up with these pixels that look at trabecular bone score. And it's the pixel density that creates this trabecular bone score number. And then the TBS is categorized as optimal, subnormal, or abnormal in terms of its quality based on the number that's seen. So a healthy control has a TBS of greater than 1.35, whereas someone with really abnormal bone quality would be an individual with a TBS of less than 1.2. And so you can see what's helpful about TBS in understanding clinically what's happening with the bone is, such as a patient with sickle cell disease, that their BMD-Z score was relatively normal, it was negative 1.9, but their TBS was 1.02. And so it tells you that maybe there's some compensation of the cortical bone in this particular patient that's trying to make up for the loss of trabecular structure. So DEXA wouldn't give you that because it's a two-dimensional image, but this TBS would tell you a little bit more and let you know, well, is this a patient that we should be being a little bit more aggressive in our therapies with to avoid overall fracture? So we looked at bone quality by TBS in patients with thalassemia and reported on this last year, and found that what was interesting is that low bone mass by DEXA was associated with overall fracture in our patients with thalassemia. So it's related to overall fracture, but not to fragility fracture. And the only thing that was related to fragility fracture was TBS. So we had fractures related to falls, motor vehicle accidents, recreational activities, but here in the green bars is the fragility fractures. And that those that had fragility fractures had a much lower TBS score. So it might be helpful to us in understanding or predicting who might have a likelihood of fragility fracture going forward. So getting to then screening guidelines, so currently our guidelines for screening and understanding bone health in our population is to start DEXA exams at 10 years of age. And my recommendation is that for our adults to also, if available, to report on TBS or trabecular bone score and a VFA or a vertebral fracture analysis. That's that lateral full spine scan that you can get by DEXA, especially if they've had any height loss or are reporting back pain to get an image of what's happening morphologically at the spine. And then to repeat the DEXA every 1 to 2 years. If there are, if low bone mass is present, to review a variety of risk factors that could be potential in inducing low bone mass in the population outside of other thal factors, hypogonadism and looking at their hemoglobin and transfusion cycle and their iron overload. And then also consider some follow-up exams such as PTH and vitamin D. Of course, I think many of us are focused on vitamin D now, but also thinking about urinary calcium and whether or not they have hypercalciuria. And I would also recommend getting a zinc, given our understanding of how zinc is involved in bone health in our population. So optimizing transfusion and chelation should really be the number one preventative measure for bone health, and so focusing on that, and then when clinically indicated to treat the hypogonadism as it occurs, diabetes and growth hormone deficiency. And though there's not a lot of literature out there yet about growth hormone treatment in our adults, our endocrinologists here are trying to get a little bit more aggressive at using growth hormone in adults, especially those that have really low bone mass, and considering that as an option. Encouraging exercise, and I'm going to get to some early results that we have in some exercise that we've been doing here, but encouraging non-contact weight-bearing activity and with some strength training to improve bone mass, and then enhancing balance and core strength. So not only can exercise improve density and geometry in bone, but if we focus on exercises that enhance balance and core strength, and it, especially for our patients who are aging, that will improve their likelihood of balance and reduce their fall risk, and that's what we want to be sure that we do. So most of what we know about in terms of exercise and bone health comes from the robust sports medicine literature, and physical activity promotes bone health. It also enhances bone geometry. I've alluded to this earlier, but if you're active when you're young, especially pre-puberty, you can not only increase density of bone, but you can increase the bone marrow expansion and the cortical density. And that then reduces your likelihood of fracture when you're older. So activity in our young patients is really formative and important. We also know that thal patients have not only low bone mass, but they have abnormal geometry from those PQCT studies. So they have smaller bones. And patients who are inactive have fewer steps per day. They have limited weight-bearing activity, which leads to reduced lean mass. And lean mass has been shown multiple times in our population of patients to be associated with lower BMD. We showed in a retrospective study here that activity in our patients that actually met the guidelines for physical activity, the CDC guidelines for physical activity, which is 30 minutes a day, 5 times a week, that they had higher bone density Z-scores in the spine and a trend towards a higher bone density Z-score in the hip. So that's, observational cross-sectional literature here that's suggesting that exercise could really be beneficial in our population. And then we followed this up with a recent study that we're just now trying to finalize here, where we took 20 patients with thalassemia and put them on an exercise regimen or an intervention and compared it to a usual state of care beforehand. And there was an initial stage of 12 weeks of exercise, and it's been extended to another 36 weeks of exercise, where we're following them longitudinally. But what we found in just the first 12 weeks of strength training twice a week and exercise 3 times a week, aerobic exercise, is that there was a trend towards an increase in hip BMD, which we're pretty excited about. And wasn't sure that we'd be able to see that this quickly, but in such a small cohort of patients to be able to show that exercise really may be able to enhance bone mass, and that could be very exciting going forward for our population. we can't forget nutrition as well. So on the last thing I think we need to be aware of is that it's important that we encourage patients to include a nutrient-dense diet that's rich in antioxidants, roughly a protein intake of about 1 grams per kilogram body weight, trying to maintain a vitamin D somewhere between 30 and 50, we think is our sweet spot for bone health in our patients with thalassemia, and then a diet that's rich in zinc. And the reason why we're interested in this diet rich in zinc is because of the work that we did a number of years ago, where we gave a population of transfusion-dependent patients 25 milligrams of zinc for 18 months and compared it to a group on placebo for 18 months. And we found that spine BMD increased by close to 4%, whole body increased by close to 3%. And in the group on zinc also had an increase in IGF-1 and improved appetite when they were on the study. So we were excited by these results and find that they're kind of fascinating because they're similar to sort of what we're seeing in some of the bisphosphonate trials. And zinc supplementation also stabilized BMD Z-score. So in the spine and hip, when the patient was on zinc, you don't have that decline in overall Z-score like we've shown in those accrual studies, that it actually stabilized. You don't have that decline. And those that were on placebo dropped about 0.3 standard deviations in Z-score over that 18-month period. So zinc was able to stabilize bone. The other therapies I just want to briefly mention at the end here that could be useful with our patients that have more severe osteoporosis or adult patients or have had a significant fracture history. There are two general categories of osteoporosis therapies. There's the inhibitors of bone remodeling, which are your bisphosphonates and denosumab, and then there's the stimulators of bone formation, like your PTH analogs, like your teriparatide and your abaloparatide, and your sclerostin antibodies. So there's two types of therapies. Unfortunately, there are very few of these trials that have been done in thalassemia that are related to a placebo-controlled trial. Most of them are these head-to-head trials, so looking at one drug in relationship to another, but I'm going to share the placebo-controlled trials and kind of a decision tree that could be useful to us going forward for our patients. So this was a trial that was done looking at alendronate. So it's an oral bisphosphonate that is given to a small group of patients, 27 patients with transfusion-dependent thalassemia and 20 patients on placebo. They were followed for 12 months. And they found a 4.3% increase in spine BMD, did not see a change in femoral neck. So just in the spine, they saw the change in this particular study, but it was a significant change in 12 months. Then there was a study that compared alendronate, which is that oral bisphosphonate, with zoledronic acid, or zolendronate, or Zometa. And this was a large trial that was published before COVID from the group in Iran. And they had 218 patients on alendronate and 157 on zoledronic acid, which is usually given by IV every 6 months. So this was 4 milligrams given intravenously twice a year, and then they followed the patients for a year. What they found in this study was that the lumbar spine BMD Z-score only improved in the group that was given zoledronic acid, and that there were greater increases in both the spine and the hip in the females that were given zoledronic acid versus alendronate. So it could be, and I think most of us do think that zoledronic acid is a stronger drug and more beneficial, and also is not have nearly as many esophageal effects or heartburn or the nausea that is shown and was common in the adverse events that was reported in this study. However, you do need to be aware that when you give zoledronic acid, that often right around the time of the infusion that you can have flu-like symptoms, which is commonly the case in bisphosphonates that are given, such as pamidronate. It's very common to get these flu-like symptoms, which dissipate over time. That was a comparison, a head-to-head comparison between the two drugs. And then denosumab has also been tested versus placebo in patients with thalassemia. This was a study that was published in 2018, the Italian group, and they had 63 patients that were randomized to either denosumab at 60 milligrams given as a sub-Q injection every 6 months, and then they would follow them for 12 months. And they found roughly a 6% increase in spine BMD. The other thing that was really nice about the study is they saw reduced pain scores, a pretty significant reduction in overall pain in the study. So that was an exciting finding in the study. So this is a decision tree that was published a couple of years ago that I think I mostly agree with and I think can be useful, but really should only be considered for our patients who've reached peak bone mass. And I would also argue that are at significant risk of fracture. So a really low bone mass, a fall risk, or some other reason for increased potential risk of fracture. So considering treatment for those who have low bone mass, an incident fracture, or have some other comorbidity that might put them at increased risk. So if they have a prevalent fracture, then you could consider a teriparatide or one of the other anabolic agents. To be mindful that the anabolic agents you can only use for 2 years, and so that's the maximum time. And so you need to think about what will happen after you use a teriparatide or a PTH type analog. If you're going to consider an anti-resorptive medication such as a bisphosphonate or denosumab, the recommendation is either an oral, like alendronate for 3 to 5 years, or zoledronic acid for 2 to 3 years. The tendency in most of the recent literature is not to increase or not to use bisphosphonates for more than 3 years in our THAL population because of the increased risk of unusual fragility fractures in the femur, femoral fractures. So you really shouldn't be using bisphosphonates for longer 3 years. And denosumab, actually, though this decision tree suggests 3 to 5 years, most of the literature that I've reviewed recommends only using denosumab for 2 years and then having an exit strategy, because it's one of those strange drugs that once you withdraw the medication, that you really need to put them on something else to maintain the bone mass that you've created. Otherwise, you're going to lose all those gains in the 6 months after the drug is withdrawn. So just a consideration of a tree for those who have significant osteoporosis and are at increased fracture risk. So I think the take-home messages here are that bone disease is really quite common in our population, and that the pathophysiology is multifactorial. And all of the patients that we see at our bone density clinic here at UCSF, the patients with thalassemia have the worst bones. And they also have so many possibilities for why that's impacting bone. So having a clinical team that is mindful for all the ways that bone can be impacted is really important for treatment and preventative strategies. Hypogonadism seems to be one of the biggest reversible factors in our population. So treating the hypogonadism early and then balancing the increase in hemoglobin concentration with transfusion while enhancing chelation to avoid iron overload and its potential toxic effects on bone would be really important. We also must keep in mind that the bone pain that many of our patients experience is not always related to osteoporosis, and there might be other reasons behind their bone pain to explore clinically. Vitamin D deficiency is common, so we should screen frequently. We typically screen here at least annually, unless a patient is commonly deficient, and we screen usually twice a year during the spring months, because that's when you typically see the nadir in vitamin D, and then at the end of the summer in those patients. Screening for by DEXA usually starts between 8 and 10 or around 10 years of age, and repeating every 1 to 2 years. Encouraging weight-bearing activity. We're hoping that we'll have more results from this current trial that we have very soon and can be able to share them publicly going forward. And then for those patients with really significant osteoporosis and have had a fracture, that there are treatment options available, but multidisciplinary care is really important to consider kind of the best therapy going forward for the patient. So with that, I think I have time for questions. I just want to thank our group here that is so collaborative and has always been supported. Of course, Cooley's Anemia for all this support, for organizing this, to HRSA for supporting this lecture. And with that, I think I'll stop. Open it up for questions. Thank you so much.
Ellen, thank you so much. As always, that was incredibly informative and thorough, and I think there was a great deal to take in there. I just wanted to ask, and I know this is a little maybe a little awkward, but if um if say there was a hematologist, a pediatric hematologist, who is now treating a thalassemia patient and never has treated one before, what are there any two or three particular things that you would advise this person to be looking out for in terms of, being on the lookout for what are the big things they should be looking out for in their patient that they don't have any experience with when it comes to bone health?
Yeah. I mean, I think that optimizing, even though they're a hematologist, they should be quite familiar with optimizing chelation and transfusion. That's going to be number one. And getting them hooked up with an endocrinologist very early. So they should be monitoring for hypogonadism very early, and not waiting till they're already 18 years of age and are hypogonadal and their bones have already been impacted. So I think that's important strategy, and finding that endocrinologist that is willing to learn about thalassemia in your center is valuable. And then the orthopedist, I don't know, they're I think less curious about bone. I think it's really the endocrinologist that will work with your team and strategizing about the best way to care for the patients. But and then encouraging nutrition and exercise. So if you've got young kids, and I think our strategy years and years ago was that we're wanting to protect them. Their hemoglobin was running low. Maybe they didn't feel like they wanted to be that active, but encouraging them to be active as much as possible, and having a nutrient dense diet so that they're getting all those bone forming nutrients early on, because those bone forming years are the most important. When they're going through adolescence, they're gaining 80% of their bone mass. And if they don't reach that genetic potential for bone, then they're always playing catch up as they get older. So I think that's really important. If that's in a nutshell. Yep.
And then kind of reversing it, let's say that you're an endocrinologist who all of a sudden is having someone with thalassemia coming to them. If they called you and like, what's going on here? What do I need to know? What do you think would be the things that you would tell them?
Right. So they need to be monitoring for an oral glucose tolerance test relatively early. So we want to be looking out for diabetes. They want to be looking out for, hypogonadism. So, ensuring that they're not falling behind. But that's usually because they're iron loaded. So if they're optimizing transfusion and chelation, they don't usually get into that trouble. Most of the patients that are these days are patients that are referred to us from outside who hadn't received optimized transfusion and chelation early on. So that's often, but I would say the endocrinologist that hadn't seen these patients before is optimizing, working with the hematologist to optimize transfusion and chelation, and then doing the early screens. So looking at an oral glucose tolerance test, looking at your sex hormone therapies, and then vitamin D, and making sure that you're not hyperparathyroid. Thyroid gland, also, of course, hypogonadal. I mean, hypothyroid is also something to be mindful of. So I think the three keys for our young endocrinologists are gonadal, thyroid, and diabetes. Yeah.
Thank you.
Mm-hmm.
So, oh,
Yeah.
sorry. Go on.
No, I was going to ask if anyone had any questions. Go right ahead, please.
So a couple things, but one is sort of a more sort of big picture bone growth health thing. I so it feels like cortical bone and that process and trabecular bone are separate processes, and some respond to one therapy and some not. First, within thalassemia, how much variation is there in patients between the two processes? And then bigger than that, when you look at all those other diseases with osteoporosis and bone disease, do they follow, similar patterns? Is it disease specific? Is it, genetics? What?
Right. I think what's interesting is that thalassemia is sort of like multiple diseases in one. If you really think about it. So
Mhm.
when it comes to bone. So I think what we're seeing from the trabecular structure is you're seeing the effects of the hypogonadism. And you saw that in those HRPCT images, that you really saw a loss of trabecular structure, which you see in postmenopausal osteoporosis. And in hypogonadal, patients outside of the thalassemia literature, you see very similar types of bone imaging. So I think that hypogonadism is affecting it. You also see that in really severe nutritional deficiencies, that you can see that, but it's not usually as dramatic as you see in hypogonadism. So I think nutrition and endocrine is having an effect on the trabecular structure. And then I think the cortical structure is affected by hemoglobin. I should also say the trabecular could be also iron loading, too. I think but that's also hypogonadism, and that's the toxic effects of iron on osteocytes and so forth. So I think iron, endocrine, and nutrition on trabecular structure. On cortical structure, I think it's hemoglobin. So it's that you're seeing extramedullary hematopoietic activity, and or the lack thereof, so increased anemia and hypoxia and stuff, but also the lack of exercise. So that's not only affecting the cortical structure, but also the geometry of the bone. So the patients that are less active have smaller bones, so their peripheral cortical shell is much smaller. And we've done some studies we're about to publish on looking at that variability in peripheral bone throughout the thal group. And found that those that had wider bone also were more active, and showed that there was actually a way that there's some robusticity, is what we call it, some ability to actually change bone in the thal population. So I can't tell you like a number per se about how variable it is, but we certainly see it, and I think it's affected by how loaded they were when they were younger. So how much in deficit they were from a bone perspective early on, and how that translates to them when they're older. Yeah. That helps. Yeah.
And then also, thank you for that. That was great. And then also, in terms of zinc, what kind of doses do you recommend? And is zinc a problem in the non-chelation population?
Right. Yeah. So that study, we gave 25 milligrams. At the end of the study, we still had about 15% of patients that were probably zinc deficient. So we might even need a higher dose. And we're actually doing a similar study right now in sickle cell patients. And we're dosing at 25 and 40, and we're trying to see what's the optimal dose. So, of course, it's a different hemoglobinopathy, and they have their own issues and challenges with the kidney and everything else. But we definitely need at least 25 milligrams. We may need a little bit more, but I'd say 25. Patients that are on deferriprone are often given 50 milligrams, and kind of across the board. But what's crazy is that study there's one study that showed that there was a relationship between zinc deficiency and deferriprone, and only 7% of the population actually became zinc deficient. So I don't think it's all patients on deferriprone, but I think a lot of oral chelators do have effects on trace elements, and not just zinc. I think also copper. So I think there could be other things going on. But getting back to your question about, is it just those that are transfusion dependent on chelators that are zinc deficient? No, we actually see it in our non-transfusion dependent patients too. And I think it's because of the increased erythropoietic activity in the patients. And so they have increased needs of zinc. And so it's a combination of increased needs because their red cell turnover is high. And also they notoriously have low zinc intakes because they were told for so long not to eat iron, foods that are really rich in iron. And all the foods that are really rich in iron are really rich in zinc. And so, so you're avoiding iron, which you should if you're non-transfusion dependent, you're not on a chelator, but then you're not getting any zinc in your diet. So it's a problem. Yeah.
And then what about zinc in the general population?
It's not that deficient. So if you look at the NHANES data, it's like maybe 5 to 10% seems to be low. The difficulty is that our marker of zinc, plasma zinc or serum zinc, is not super specific. So you can be deficient and your plasma zinc could be normal, and vice versa. So it's not very sensitive or specific. But the way that you test for zinc deficiency, which is not very helpful in adults, but in kids, the way you test for zinc is you give them zinc, and if they grow better, then you know they're deficient. But in our adults, we can't do that. So it's a crude marker, but we use it. And so in the NHANES data, that's what we have. But I don't know that it's perfect, in terms of our overall risk. Yeah.
Thanks.
Yeah.
Are there any other questions?
Maybe this a high level, maybe forgive me if it's too high level, but just thinking about the trajectory, say maybe somebody that's aging with thalassemia, and there may have been different guidance. Is there any recommendation to kind of catch up, essentially to, help increase that bone density? Is there anything? And then number two, like how is that messaging to those patients that have been given, they had different guidance? Just think about those two questions.
Right, right. I think that's the crux actually, because so many of our older patients are now living with really low bone mass, and there's a combination of the really low bone mass and bone pain and excruciating bone pain, and they were told for so long that that there was conservative therapy, that really we don't want to use bisphosphonate because either you're a female and you're of childbearing age, and if you give them a bisphosphonate, it's in the bone for 8 years, and so we don't want to use a bisphosphonate in a childbearing female. But so I think some clinicians are getting a little bit more aggressive at using bisphosphonates in our older patients, especially if they have bone pain, because the denosumab trial and some of the zoledronic acid trials are showing that it can have positive effects on pain. So that could be beneficial. But we want to use them not liberally, conservatively in the patients that really need them. So if they've got a DEXA of -3, they don't have bone pain, they're not fracturing, and they're able to be super active, I don't think that that's the patient that we would be treating with a bisphosphonate right now. So there's, I think that's one part. But what can they be doing to either stabilize or potentially improve bone mass? And I think that there are a couple things. I think that in the DEXA study, the zinc study, we had patients up to 30 years of age in that trial, and they still had gains in bone. We also did a trial using vibration therapy years ago. This was also a Cooley's funded trial. And we had patients stand on a vibrating platform. And these platforms that are available over the counter, they're not cheap, but they're available. And we saw an increase in bone density in the vibration trial. And those were adults who are adherent to standing on it 20 minutes a day. It's, just so there are ways that we think that we can actually gain bone. We potentially think this exercise study might be similar. So we have patients up to 40 years of age in this study, and we'll have to do a sub-analysis of the older patients versus the younger and look at it. But I think that there are ways that we can actually enhance bone, not just maintain it, using some of these less traditional means like nutrition, exercise, and vibration, potentially. Yeah. Yeah.
Thank you.
Mhm.
One more DEXA question.
Yeah.
So in the main groups I work with, they get a TBS.
They do. Good. Okay.
But what percentage of places for patients remotely, do most machines have it or?
No. Yeah. So, even I would also say a lot of places don't even have DEXA anymore because the reimbursement rate for DEXA is so low that some of our outlining clinics don't have it. And so they'll refer their patient to come see us, but so if you have a DEXA, that's one thing. The software for the TBS is about $10,000. So they have to, decide that they want to invest in that. And usually the folks that would have that are folks that are seeing older patients. So you're not going to see it at a pediatric institution because it's not used as commonly. So that's probably where you are. The VFA is being used more often. And we do it on all of our sickle cell patients because of the biconcavity malformations that we see in our sickle cell patients. We're using it more in the thal now too, because the exposure of DEXA, so the radiation exposure to the patient by DEXA is so much lower than a lateral spine scan. So you can screen by DEXA, and then if you see something, then you can refer them to have that lateral spine scan or an MRI, which is also like 3 times the cost. 4 times the cost. So I think it's a good screening tool if it's available at the center. That's helpful. Yeah.
Thanks.
Mhm.
Are there any other questions for Dr. Fong?
Our N of 4. I love it. Thanks, you guys.
All right, then I'm going to just say Thank you very much, Dr. Fung, for joining us. And thank you for our audience for being here. And we appreciate everything that you've told us and wonderful information. And we will look forward to seeing what develops over the next few years.
Sounds great. All right. Thank you all.
Thanks for this.